So today we'll be talking about ARNI and its effect on HFrEF and HFpEF patients, and what is the new pathway for the national consensus. There is a 15-point consensus we'll be discussing today. ARNI in HFrEF and HFpEF. Heart failure can be deadlier than many of the cancers. Like if you look at the 5-year death rates for breast cancer, it's 11%, Hodgkin's lymphoma 15%, non-Hodgkin's 31%, colon and rectal cancers 35%, leukemia 43%, and heart failure around 50% people are dead by 5 years. And in fact, 90% people are dead by 10 years. So it is very, very deadlier than the most of the cancers also. It's a progressive condition with a very high mortality, and there is a chronic decline where there are acute episodes of decompensation, and gradually there is a decline in the symptoms and the quality of life of the patients, and eventually there is repeated hospitalizations and death. You can see heart failure patients are at a very high risk of death and hospitalizations. 9 out of 10 patients are asymptomatic even with the current standard of care treatment. And 1/3 of patients with heart failure with reduced ejection fraction are at very high risk of hospitalization or cardiovascular death, including those people who look very stable. Now, the mean survival, if you look at, after one episode of heart failure hospitalization, that is around 2.5 years, 2.6 years rather, to be more precise. But after second hospitalization for heart failure, it becomes just 1.8 years. After third, it becomes 1.5 years. And repeated fourth hospitalization, the survival is hardly 1.3 years. Yes, it is definitely different. If you look at the bigger picture, then the global scenario, mean age of the patients is around 73 years, and in India, it's hardly 53, 20 years lesser as compared to the Western world. The in-hospital mortality is around 3.8% in the global scenario, and in India, it's around 9 to 10 times, 31%. Post-discharge mortality at 6 months is hardly 8% in the Western world, and in India, it is around 26%. So basically, the patient with heart failure in India are affected at a younger age, have very high mortality rate, and also after discharge within 3 months to 6 months, most of the hospitalizations or rehospitalizations, that is the vulnerable period which we call it, most of them are readmitted and mortality is very high. Now, heart failure survival rates, if you look at the inter-CHF study, around 23% of the Indian patients with heart failure die within a year of diagnosis, and we are just comparable only to Africa, which are around 33%. Otherwise, if you look, very high mortality at 23 years, and the survival rates of heart failure are worse than most of the cancers which are reported, like the bowel cancer, breast cancer, or prostate cancer, or Hodgkin's lymphoma, non-Hodgkin lymphoma, or any other cancer. The prevalence of heart failure in India, the truths, there are around 8 to 10 million patients with heart failure in India. That is around 1% of the population. And most importantly, the post-admission mortality is 20 to 30%, which is very, very high as compared to the Western world. The medication adherence is hardly 25 to 50%, which is very, very less as compared to the Western world. There's a younger population with heart failure. And one of the studies, the Trivandrum Heart Failure Registry, had showed that around 55% of the patients with heart failure had diabetes, and hypertension around 40% of patients. 5-year mortality and readmission rates in patients with heart failure in India. If you look at the Trivandrum Heart Failure Registry, 3 out of 5 patients had died within 5-year follow-up. Lack of guideline-directed medical therapy in patients with heart failure with reduced ejection fraction and frequent readmissions were actually associated with an increased 5-year mortality. Only 25% patients were discharged from index hospitalization and guideline-directed medical therapy. And I think this is one of the most important parameters, and interventions aimed at increasing guideline-directed medical therapy may improve the heart failure outcomes in India. Now, what are the goals of therapy in heart failure treatment? Naturally, most important is to increase the survival, reduce the mortality and premature deaths, mainly in the form of sudden cardiac death or death from progressive heart failure or pump failure. We have to reduce the hospital admissions because it's a very unpleasant feeling for the patient, for the family, distress for the family, costly for the family, very bad prognostic indicator, and also it worsens the survival chances. And more importantly, make the people feel better, because if the symptoms and quality of life of the patient, because the patients with heart failure cannot go to the bathroom, cannot walk, cannot do their daily activities. And if you improve that, if the people feel better with the treatment and they can lead a normal life, that is excellent for them and for their survival. Now, if you look right from 1986 with the HFrEF trial for the hydrolyzine isosorbate dionated combination to various ACE inhibitor trials like Consensus, SOLV-T, SOLV-P, HFrEF, Atlas, to mineralocorticoid receptor antagonist trial like RAILS, to beta blockers trials like MERIT-HF, CBIS-2, CBIS-1, USCP trial, Copernicus trial, digoxin trial like DIG. There are a lot of trials which were done in the last maybe from 1986 to around 2001. And eventually there are even more trials I'll show you. If you look at various other trials like hydrolyzine isosorbate dionated combination 2004 AF trial, which have shown tremendous benefits. Mineral receptor antagonist trial like Emphasis HF, beta blocker trial like COMET, which compared carvedilol with metoprolol, seniors trial. And you look at ARNI trial is one of the latest trials like Paradigm HF trial in 2014. But if you look at the ARB trials, the candesartan trial like CHAM altered, CHAM added, VALHEF trial, HEAL trial with losartan, ivabradine SHIFT trial had shown 19% mortality benefit. ICD and CRT trials like Companion, SCAD-HEF, CARE-HF, MEDIT, CRT, RAFT, and various other trials. So they all have shown. In fact, there were trials which compared atrial fibrillation patients whether rate control was good or rhythm control was good, AF-CHF trial, or exercise prescription also was checked in various trials like HF Action trial. So there were tremendous trials right from 1986 to around 2014. And the latest additions were Paradigm HF and DAPA HF trials. DAPA is a dapagliflozin trial we'll be discussing. So then came a big step forward in the form of the Paradigm HF trial. Now, what is this Paradigm HF trial? It took patients with on ARNI in patients with heart failure with a reduced ejection fraction less than 40%. Most of the patients were in NMHA class 2. Few of them were in NMHA class 3 and 4 were very less. Primary endpoint was cardiovascular mortality or hospitalization for heart failure. And they compared enalapril 10 milligram twice a day with ARNI 100 milligram BD. Maybe starting was 50 BD, then 100 BD to maximum dose of 200 BD. Now, if you look, enalapril 10 milligram BID dosage is a very, very rarely used combination. This dose is very, very less. Generally, hardly 2.55 at the most. 10 milligram is the dose generally people use. So this is a very significant dose and very high dose, and this was compared with ARNI. What were the eligibility criteria? Ejection fraction less than 35%, more than 4 weeks on treatment with ACE inhibitors, ARB or beta blockers, anti-proBNP levels were raised, aldosterone antagonist should be considered for all patients, but exclusion criteria were like history of angioedema or EGFR less than 30, hypotension, requirement for both ACE inhibitors and ARB. We all know that if you combine the two, the mortality goes up. High potassium levels, acute decompensated heart failure was not included, and severe pulmonary disease was also not included. So largest mortality morbidity trial is this trial in patient with HFrEF. It is the most geographically diverse trial in patient with HFrEF. In fact, a lot of patients from India also were taken, around 15-17% of patients from India also in that trial. And it is one of the most racially diverse heart failure trials which is available. Effect on ARNI was enalapril on clinical outcome with patient with HFrEF in the Paradigm HF trial. If you look, these benefits were over and above that seen with enalapril, that too at very high dose of 20 milligram per day. Cardiovascular deaths were less by 20%. Heart failure hospitalizations were lesser by 20%. Overall mortality was lesser by 16%. Heart failure deaths by less by 21%. And even sudden cardiac deaths, which is more common in NYHA class 2 patients or maybe less sicker patients, and that also was less by 20%. Now, if you look at the medical therapy for stage C heart failure with reduced ejection fraction, the magnitude of benefit which was demonstrated with the various guideline-directed drugs like ACE inhibitor or ARB was 17% mortality reduction and hospitalization reduction, heart failure reduction by 31%, and number needed to treat was hardly 26. Beta blockers showed a reduction in mortality of 34% and heart failure hospitalization by 41%, and number needed to treat was only 9. Aldosterone antagonists like with the RAILS trials or FSS trials had shown 30% reduction in the mortality and also 35% reduction in the heart failure hospitalization. And isosorbate dionated combination, AHF trial or VHF trial, 43% reduction in mortality. Number needed to treat only 7, and 33% reduction in the heart failure hospitalization. They were all significant numbers. Now with ARNI, you see a 20% reduction in the mortality over and above that seen with an ACE inhibitor like enalapril. The number needed to treat was only 32, and the reduction in the heart failure hospitalization was 21% over and above enalapril. NYHA class changes were also seen with ARNI. Like if you see in this bar diagram, after 30 days of treatment with ARNI, there was an improvement in NYHA class of at least one class in around 35% of the patients. ARNI, before ARNI treatment, only 8% of patients were in NYHA class 1. But after treatment with ARNI, around 33% of patients were in class 1. And you can imagine class 1 is, I think, very, very less symptomatic patients. In fact, they measured this by a scale called as Kansas City Cardiomyopathy Questionnaire Scale. And they had shown an 8.4 point improvement and even 10 point improvement after 1 year. So that was the case. What is the effect of ARNI versus enalapril on clinical outcome in subgroup of heart failure patients? Irrespective of the age, whether less than 75 or more than 75, irrespective of ejection fraction of less than 35 or more in less than 35 and lesser in more than 35, EGFR less than 60 or more than 60, SBP less than 120 or more than 120, NT-proBNP raised or not very highly raised, ARNI was found to be superior to ACE inhibitor across all subgroup of chronic heart failure with reduced ejection fraction patients. Slightly, it was even slightly better if you look at the ejection fraction less than 35% as compared to the ejection fraction more than 35%. And the clinical efficacy of ARNI in Asians, if you look all over Asia in Paradigm HF trial, the overall primary endpoints were lesser, cardiovascular deaths were lesser, heart failure hospitalizations also were lesser, and all-cause mortality also was lesser in cases of ARNI as compared to enalapril. The illusion of stability in heart failure is a big issue. 20% of stable patients, like the patients who never had a heart failure hospitalization in Paradigm HF trial, had a primary event. In fact, 17% of them died during the course of the trial. Of stable patients who experienced a primary event, death preceded heart failure hospitalization in around 50% of patients. In fact, the 60% of these deaths were sudden deaths, sudden cardiac deaths. So ARNI should be started as early as possible. Do not wait till the patient deteriorates, because he can have a sudden cardiac death also. There's a 2022 ACC AHA consensus guideline, which recommends ARNI as a first-line treatment, class 1A recommendation for HFrEF patient with NYHA class 2 to 3 symptoms to reduce the morbidity and mortality. But if the patients with the previous or current symptoms of HFrEF, use of ACE inhibitor is beneficial to reduce the morbidity and mortality when the use of ARNI is not feasible. But generally that is not the case. ARNI generally is feasible. And if it is not feasible at all because of the cost or any other issues, then ACE inhibitors can be used. If patients who are intolerant to ACE inhibitor because of cough or angioedema, then and when the use of ARNI is not feasible, then the ARBs can be used. And in patients with previous or current symptoms of chronic heart failure with reduced ejection fraction, if ARNI is not feasible, treatment with an ACE inhibitor or ARB can have some economic benefit for the patient. So if not possible, then only use an ACE inhibitor or ARNI, ACE inhibitor or ARB. Otherwise, ARNI is the first drug of choice. In acute decompensated heart failure, different from de novo heart failure. De novo heart failure is a distinctive phenotype from acute decompensated heart failure. Like if you compare a decompensated heart failure patients, they generally have an older population, worse baseline status, laboratory findings are abnormal, and known history of heart failure is there. Unlike de novo heart failure, which there is no history of heart failure. There are a lot of comorbidities, right from obesity to AF to diabetes to COPD, stroke, post-bypass, post-angioplasty in acute decompensated heart failure, unlike de novo where there is no such history. Trigger events can be medication non-compliance, infections, diet, cardiovascular complications or interventions, drugs. But in de novo heart failure, cardiac ischemia or valvular incompetence like acute MI or acute mitral regurgitation, inflammation or toxic drug-induced results generally are there. Now, clinical presentation is dyspnea, orthopnea, lower limb edema, ascites, weight gain in cases of acute decompensated heart failure, and more like a cardiogenic shock and acute pulmonary edema, more rapid and dangerous kind of sudden presentation in de novo heart failure. And the main pathophysiology for acute decompensated heart failure is pulmonary and systemic vascular congestion caused by LV dysfunction, maladaptive neurohormonal activation, fluid overload, and redistribution. unlike acute hemodynamic derangement caused by LV systolic dysfunction like an MI in de novo heart failure. So these two are different subsets. As per the Pioneer HF study, hospitalized patients with acute decompensate heart failure, ejection fraction less than 40% were looked at, and around 900 patients were there in the study. They were stabilized while still hospitalized. Like if SBP was more than 100 in prior 6 hours, there were no symptoms and BP was not dropping. There was no increase in inotropes over a period of 24 hours, no increase in IV diuretics or vasodilators in the last 6 hours. Such patients were taken in the study and were compared enalapril 10 milligram BD versus ARNI 200 milligram BD was the dose. And they were studied. The study was followed up for around 8 weeks. And what they found was there was a significant decrease in NT-proBNP levels and improved clinical outcomes like even cardiovascular death and hospitalization. As you can look at these Kaplan-Meier survival curves, and there's a significant difference between enalapril and ARNI vis-a-vis change in NT-proBNP levels or cardiovascular death or hospitalization. Now, there were pre-specified subgroup analysis also done in de novo heart failure patients, and in all cases, whether de novo, whether worsening chronic heart failure, whether patients were on ACE inhibitors or ARB or not on ACE inhibitors, in all kind of patients, there was significant improvement in NT-proBNP levels at 8 weeks once the patient was switched, or rather compared with an ARNI as compared to an ACE inhibitor. Such improvement in early clinical outcomes would be lost in a scenario of ACE inhibitor or ARB pretreatment. Pioneer HF, if you look again, the change in NT-proBNP levels were very significant, and cardiovascular death and heart failure hospitalizing also was very significant. And you could see early clinical benefits as early as 14 to 15 days. So I think you have to start ARNI very, very early in the, as per the Pioneer HF trial, ideally before discharge. So there were 2 studies, Global Report Heart Failure Registry, and 43% of the patients had de novo heart failure. Now the range was around 20% in North America to around 80% in Southeast Asia, but around 40-45% patients were had de novo heart failure. Similarly, in the PREVENT study, 66% of patients were newly diagnosed heart failure with reduced ejection fraction patients. So de novo heart failure is an increasing challenge, and ARNI keeps de novo heart failure patients out of the hospital and helps them live longer. Now you remember that if the patient is hospitalized for heart failure, there is a very high chances that he might get re-hospitalized within first 3 months. And I think this vulnerable period is a very, very important period, and there is a significant lower incidence of composite of cardiovascular death or heart failure re-hospitalization in de novo heart failure patients with HFrEF, especially when they started on ARNI. So we want to prevent that re-hospitalization and acute decompensation, rather, or de novo heart failure decompensation. That's why we start an ARNI earlier in a patients. There was a transition study also, which compared the initiation of ARNI shortly after hospitalization for acutely decompensated heart failure in patients with newly diagnosed or de novo heart failure. And this study also suggested that you should start ARNI early, ideally before discharge. You see, ARNI improves cardiographic parameters in de novo hospitalized patients. Like there was a reversal of remodeling. Now, the drugs like beta blockers also have helped ejection fraction by around 4 to 5%, maybe ACE inhibitor by 1 to 3%, 1 to 4%. But ARNI improved the ejection fraction by around 14-15%. And more importantly, the remodeling also was improved. Now, remodeling is very, very important, especially the LV and diastolic volume, rather LV and systolic volume is even more important than LV and diastolic volume. LA volumes, E by E prime ratio, all these parameters, and including the NT-proBNP levels, they actually improve within starting of the ARNI. Also, the troponin T concentrations, the highly sensitive troponin T concentrations also were reduced, rather normalized once the patients were started on ARNI. More de novo than prior heart failure with reduced ejection fraction patient achieved target dose at week 10, 56% versus 45%, if you can look at this. So the transition study, what are the results? First line initiation of an ARNI in de novo heart failure patients with reduced ejection fraction alongside the initiation of other guideline directed medical therapy is feasible and is associated with a better risk profile. early intervention with sacubitril valsartan should be considered to delay disease progression in patient with de novo heart failure with reduced ejection fraction. In fact, McMurray et al. And Milton Packer have also suggested that the 4 foundational drugs like ARNI, beta blockers, evidence-based beta blockers like bisoprolol or carvedilol or metoprolol, aldosterone antagonists, and SGLT2 inhibitors, these all 4 in the minimal possible dosages should be started as early as possible, ideally within 1 month of hospitalization. 2021 update to the 2017 ACC expert consensus decision pathway for optimization of heart failure. Let's discuss that. So heart failure with reduced ejection fraction stage C. First of all, start an ARNI ideally, or an ACE inhibitor or ARB. ARNI is preferred choice, along with a beta blocker, which is evidence-based, as I've mentioned, bisoprolol, metoprolol, and carvedilol, whichever. Then diuretics also. Now, if the patient does not have creatinine around, it is lesser than 2.5 and eGFR is more than 30, potassium is okay, you can always add an aldosterone antagonist. If the patient has eGFR, which is meeting the criteria, like less than 20 or less, maybe at least more than 20 or more than 30 as per DAPA or EMPA studies, the SGLT2 inhibitor can be added. For patient with still persistent overload or heart failure, diuretic dose needs to be increased. For patients being symptomatic despite the starting of ARNI, beta blocker, aldosterone antagonists, SGLT2 inhibitors, you can, especially in the black patients, you can use a hydrolyzine asorbate combination. And for patients with, despite the maximal tolerated dosage of beta blocker, if the heart rate is more than 70, you can add ivabradine to that as per the HFrEF trial, which shows 19% mortality benefit. So clinicians should aim to achieve optimal guideline-directed medical therapy within first 3 months only, I will say, at the most 6 months of initial diagnosis of heart failure. ESC 2021 guideline also recommends ARNI as the first-line therapy instead of ACE inhibitors in HFrEF patients. You can see in any patient with HFrEF, first line is class 1A recommendation is ARNI. If ARNI is not feasible, ACE inhibitor can be used. If patients are intolerant to ACE inhibitors because of cough or angioedema and ARNI is not feasible, then ARB can also be used, but preferably an ARNI is the first choice. And if it is not feasible, then only you use other drugs. Now see, if the patient is already on ACE inhibitor, most important thing is to give a gap of 36 hours because of the ACE enzyme, bradykinin levels, they go up. And in the ARNI, because of the sacubitril, that also enzyme, it's a, endopeptidase inhibitor. So because of that also bradykinin levels go up. So we don't want to overlap because there will be unacceptable angioedema or cough to the patient. So ideally, we should give a gap of 36 hours if the patient is on ACE inhibitor before switching to ARNI. But that is not the case with an ARB. If the patient is on ARB, you can straight away shift the patient to ARNI because the ACE enzyme is not inhibited because of the ARB. And what is the equivalent dose? If the patient is of less than 10 milligram per equivalent of enalapril or less than 160 milligram of valsartan, you can start with a 50 milligram BD dosage. But if the patient is taking more than 10 milligram of enalapril per day, or more than 160 milligram of valsartan per day, you can straight away start with 100 milligram BID dosages. And in every 2 to 4 weeks, you can gradually keep on increasing the dose of the patient with ARNI. For ACE inhibitor also, if the patient generally it's not, but if the patient is on ACE inhibitor, you can gradually keep on increasing dose every 2 weeks. Similarly, for the beta blocker also, to the maximum tolerated dosages. So reasons for failure to tolerate ARNI, most important, one of the biggest reasons is hypotension. Initially, the patient, if the patient has intolerance or, not tolerating this molecule, generally 50% of the patient, it's because of hypotension. And second most important reason being around 20-25% patients are because of the increase in the creatinine levels or hyperkalemia. And rarely GI symptoms also are there. And similar other targets are reasons for the not achieving the full dose of the ARNI. But what are the benefits? If you look at this slide, if you achieve 100% of the target dose or 50% to 100% or even less than 50% of the target dose, equivalent to 50%, the patients still benefit. In fact, I have seen tremendous improvements in the ejection fraction with the lesser dose of 50 milligram BD only. So ideally, we should try and target the patient to get the maximum tolerated doses every 2 to 4 weeks. But if the patient is not tolerating because of hypotension, hyperkalemia, or creatinine increase, you can continue the dose which is tolerated the best. Like if the 50 BD is only the tolerated dose, you continue that. If 100 milligram BD is the dose which is tolerated maximum and you are not, you cannot increase it further, okay, the benefits are tremendous and you should continue the dose which is tolerated situations. Yes, ARNI reduces the risk of cardiovascular death and heart failure hospitalization in HFrEF patients with low BP. In fact, there is a 12% reduction in the risk of cardiovascular death or hospitalization in HFrEF patients with low BP if you compare with enalapril. What is the risk of hypotension? Yes, we have discussed that. There is definitely some more risk of hypotension. There is 12% risk with enalapril and 18% risk with ARNI, as you can see in this Kaplan-Meier curve. But it does not lessen the advantage which ARNI has. Even if there is hypotension, you try and decrease the. I'll tell you how to manage. So most importantly, you have to. Many of the patients are volume depleted, so you have to correct the volume or salt depletion in such patients, and start the ARNI with the lowest possible dose. But still, if there is hypotension, you should actually down titrate the dose of diuretics, or maybe you start with a lesser dose, or you can decrease the dose of beta blockers and use ivabradine also in such patients. But what is recommended is don't stop ARNI. Try to be very gradual. Volume after correcting the volume status, after correcting or decreasing dose of diuretics, you can in that case maybe decrease the dose of mineral receptor antagonist also if required. Or maybe you can decrease the dose of beta blockers and change it to ivabradine, which is more hemodynamically stable also. But yes, you don't stop it. Be very gradual. Don't try to increase the dose every 2 to 4 weeks. Make it 6 to 8 weeks. Be very gradual in increasing the dose, or you stop at whatever dose is tolerated. But despite all these measures, if the patient still has hypotension, then you'll have no other option but to stop the ARNI. You should straight away put ICD or CRT, or you should wait. So in the Egyptian Heart Journal, there was a wonderful study by Navjot Kaur, whether introduction of ARNI will reduce the need of device therapy like CRT or ICD in patient with reduced ejection fraction. Let's see. So what are the recommendations for ICD in a patient with heart failure? And ICD is recommended to reduce the risk of sudden cardiac death and all-cause mortality in patients who have recovered from a ventricular arrhythmia and have a survival of at least 1 year ahead. Then yes, you can put an ICD in such patients. And ICD is recommended to reduce the risk of sudden death and all-cause mortality in patients with symptomatic heart failure with ejection fraction less than 35%, more than 3 months of optimal medical therapy, provided they are expected to survive more than 1 year. So generally in MI patients, if the patient has MI, you have to wait at least 40 days and then only look at the ejection fraction and then put an ICD. Or if the patient has a cardiomyopathy, dilated cardiomyopathy, then also the ejection fraction is less than 30-35%, you can put an ICD to prevent sudden cardiac death in such patients. So if patient with having symptoms because of HFrEF, treat all the reversible causes like maybe beriberi or any selenium deficiency or thyroid or so many other reasons which are there. But if the patient is still symptomatic and has NYHA class 2 symptoms, LVBB is there, and especially it is more broad QRS like 150 milliseconds or more, you can put a CRT to improve the ejection fraction of the patient. But if the patient is symptomatic and the QRS is narrow and ejection fraction is still less, 30-35%, you can add an ICD to such patients. But there is a lot of gap in the evidence, like there are non-responders to the treatment. Because of the frequent VPCs or progressive heart failure, there can be no response to treatment many a times. So what you can do is replace the ACE inhibitor with an ARNI in such patient because it improves the ejection fraction, reverses the adverse cardiac remodeling, decreases the VPC and sudden cardiac death also of such patients. And there is a chance that such patients, once the ejection fraction improves, he might not require a CRT and ICD. So if you look at the Trivandrum heart failure registry, 55% of patients who were hospitalized for heart failure had diabetes. And if you look in chronic heart failure patients, the prevalence of diabetes is around 30%. And in diabetes patients, the prevalence of heart failure is approximately between 10 to 30% as per the various trials. So ARNI reduces the cardiovascular death and heart failure hospitalization, improves the quality of life, irrespective of glycemic status of the patient. If you look, there is a 20% reduction in cardiovascular death and even heart failure hospitalizations. You can see effect of ARNI on glycemic control. It actually improves the glycemic control to a certain extent. The HbA1c levels also go down very minuscule, hardly 0.14% decrease in HbA1c levels. In fact, around new insulin usage is decreased by 30%. And fewer patients were started on OHA therapy once they were started on ARNI. So definitely it helps in the control. HFrEF starts at the heart and then goes elsewhere. But HFpEF starts elsewhere, everywhere, and ends at the heart. So basically, HFpEF patients are more sicker patients. Generally, preserved ejection fraction means ejection fraction more than 50%. And generally, such patients are females, obese, diabetics, hypertensives, atrial fibrillation, and maybe COPD also. And there is a lot of metabolic stress, aging, cardiac remodeling, vascular stiffening, sedentary lifestyle. Eventually, that leads to heart failure. That is heart failure with preserved ejection fraction. There are a lot of studies which have failed in HFpEF patients, like the CHAMP-PRESERVE study, CHAMP-PRESERVE with candesartan, I-PRESERVE study with irbesartan, PEF-CHF study with perindopril, TOPCAT study with spironolactone. Even DIG trial did not show any benefits. There were a lot of failed trials in HFpEF. And clinical outcomes, if you look at HFpEF and HFrEF in the various observation studies, they were actually similar. The patients have similar symptoms. So there were a few trials like Paramount trial, which showed improvement in the soft domains with the ARNI, like improvement in the NT-proBNP levels, improvement in LA size, improvement in NYHA class also was seen. Paragon heart failure trial also was a randomized double control trial which compared valsartan with ARNI. And if you look, the composite of total first and recurrent heart failure hospitalization cardiovascular deaths were seen, and they were definitely better. And there were a lot of improvement in the NYHA class of the patients, and KCCQ questionnaire, cardiomyopathy questionnaire was there. And also worsening renal function and all-cause mortality, they were better in the Paragon heart failure trial. See, you can see heart failure hospitalization and cardiovascular deaths. Although deaths were not very, very significant difference, but definitely significant difference between the heart failure hospitalizations. You can see there was some difference, heterogeneity was seen in this Paragon HF trial. Like the males did not benefit that much, the females they benefit more. So as I've mentioned, the females generally have HFpEF more commonly, and males generally have HFrEF more commonly. And ejection fraction at a cutoff of 57% was found. That if ejection fraction, if it was more than 57%, there was no major benefit seen. But up till 57% of ejection fraction, there were definite benefits which were seen. And as I've mentioned, HFpEF is hardly ejection fraction more than 50%. So I think that 40 to 50% area, definitely they benefited. And these benefits, the primary composite of endpoint and various parameters, if they compared, they were all seen. Lesser the ejection fraction, more the benefit. But once the 57% cutoff was seen, then the ejection fraction, if it went up more than 57%, the benefits are not seen in the Paragon HF trial. Yes, so the EF cutoff for the benefit was 57%, which is as good as normal only. Now, Butler et al. Had compared various patients, they are divided such patients with HFrEF to maybe HFpEF into various categories, right? From ejection fraction less than 25% to 25 to 30, 35, 35 to 40, and so on, 50 to 60, and more than 60. And what he could find was that lesser the ejection fraction, more the mortality and morbidity and heart failure hospitalization benefit in patients. Definitely, the American College of Cardiology has recommended that patients can be started on heart failure with ARNI patients. HFpEF patients can be started on ARNI irrespective of the ejection fraction. And all the 4 evidence-based drugs, as I've mentioned, like ARNI, SGLT2, MRA, and even maybe beta blockers, they can be started within as early as 1 month of the treatment. So definitely there's a new FDA indication which opens up for ARNI in HFpEF patients. So angioedema, as was mentioned, there was a drug called as emapatrilat in Overture trial, which actually was a ACE inhibitor along with sacubitril, and it was banned because of dangerous angioedema. And such angioedema, like grade 3 angioedema, is never seen with ARNI. But yes, if the patient has any history of angioedema, that this molecule is not to be given. And this angioedema was not very significant, hardly 0.5% versus 0.2%. Hypotension, as I've mentioned, is the only issue, only in 18% of patients, and that can be also managed very well as compared to 12% in enalapril. Impaired renal function was lesser, 3% versus 4.5 in enalapril. Hyperkalemia 12 versus 14% in enalapril. Cough also was lesser in ARNI as compared to enalapril. And renal safety, the risk of hyperkalemia associated with the use of MRA was lower among those treated with ARNI in those treated as compared to enalapril. So basically, if you start the patient on ARNI, the hyperkalemia which happens because of MRA at times, if you combine them with ACE inhibitor, goes down. In fact, SGLT2 inhibitors also have shown that the tolerability of MRA is improved and the hyperkalemia also is lesser. And what are the contraindications that I mentioned? Within 36 hours of ACE inhibitor use, don't use it because you can have angioedema or a lot of cough. Any history of angioedema, pregnancy, lactation, severe hepatic impairment like child C. Aliskiren use, aliskiren generally not used now, or any hypersensitivity drugs. Some caution, because mild to moderate EGFR decrease, there is no need to adjust the dose. If EGFR is less than 30, you have to maybe give a 50 milligram BD dosage, at the most 100. Hepatic impairment, like no starting dose adjustment required for child A class, and hardly 100 milligram BD dose in higher class of child. Systolic BP less than 100, volume depletion, renal artery stenosis, these are also, they have to be slightly cautious in starting this molecule. What are the drug interactions? ACE inhibitor is contraindicated. Naturally, aliskiren should not be used with this molecule. Anyway, aliskiren is not used. Potassium sparing diuretics, if they are used, look for hyperkalemia, especially in patient with diabetes or hypoaldosteronism. NSAID should be avoided. Lithium, if the patient has some psychogenic tendencies, there is a risk of lithium toxicity. And naturally, birth control pills containing drospirenone should be avoided with this molecule. Hardly, maybe not even maybe hardly a single digit person, maybe 1 to 2% only patient. Otherwise, generally it is not. If the patient is tolerating ACE inhibitor, they will always tolerate an ARNI, except watching for hypotension, which is also around, say, as I mentioned, 12% in enalapril and 18% in slightly more in ARNI. So you have to avoid high potassium diet in such patients, rather give them low potassium diet. Small dose of loop diuretic can actually help. K-bind can be used, sachet, or aspirin nebulization can be done. Glucose infusion, glucose insulin infusion can also be given. And patiromer will be is a new drug, and it will definitely be a boon once it is available for such kind of patients. ARNI in daily clinical practice, there was the data from 427 patients, and ARNI withdrawal in patient with heart failure and reduced ejection fraction was independently associated with increased all-cause mortality. So there is a very high tendency that if the many of the physicians or maybe cardiologists also at times think that the patient has improved ejection fraction now, and if the patient has responded well, why unnecessarily give this molecule and stop it? But in fact, there is a study, TRADE-HF trial, which showed clearly that if you stop ARNI within 6 months, all the benefits which you have achieved in the ejection fraction and LV volumes will actually go away. So you have to continue this molecule, and ideally continue it at a dose which is a maximally tolerated dose. Improved ejection fraction is an entity apart from LV. If you divide 3 categories of heart failure with ejection fraction, as per the heart failure guidelines, reduced ejection fraction is less than 40%. Mid-range ejection fraction or mildly reduced ejection fraction is around 40 to 50%. and more than 50% is preserved ejection fraction, HFpEF. Now, improved ejection fraction patients are such patients who have a 10-point increase in ejection fraction above 40%. So basically, they have ejection fraction which is less than 40% to begin with, and with the treatment with various ARNI and other drugs, the ejection fraction improves by at least 10 points to end up being more than 40%. So for example, if the patient has ejection fraction of 30% to begin with, and there is a 10-point or more, like the 15-point, I'll say, improvement in ejection fraction, so that the ejection fraction now is 45%. So to begin with, it was 30, now it is 45. Such patients are called as heart failure with improved ejection fraction. There is a separate category for such patients. Now, with that, I tell you that now if you compare HFpEF patients, hardly 60 to 90% remain HFpEF. Maybe 10-20% actually, deteriorate ejection fraction is deterioration in ejection fraction is seen, and 10 to 20% will become with mildly reduced ejection fraction patients. In fact, 2 to 20% can be reduced ejection fraction patients. Similar for the mildly reduced ejection fraction patient, 30 to 40% only will remain, and maybe 20-30 can have a reduced ejection fraction, 30-40 can have an improved ejection fraction. Similar for HFrEF patients. HFrEF patient around 60 to 80% can remain the same, but many of them, maybe 10 to 20%, will actually have HFpEF, absolute improvement in ejection fraction, more than 50%. Or there will be a 10 to 20% another subset which have mildly reduced ejection fraction. Maybe the ejection fraction will be 40 to 50%. So basically, this is a continuum. It is not a separately, separate entities. They are in a continuum, and reduced ejection fraction can actually change with the treatment, and it can be an improved ejection fraction also. And what are the 2022 AHA guidelines? Improved LVEF is used to refer to those patients with previous HFrEF who now have ejection fraction more than 40% and have at least a 10-point improvement from the previous ejection fraction. And what are the recommendations in patients with mildly reduced ejection fraction patients? Guideline-directed medical therapy should be continued to prevent relapse of heart failure and LV dysfunction, even in patients who may become asymptomatic. So even if the ejection fraction is improved, don't stop this molecule, otherwise the benefits might go away. So what are the pearls of consensus? ARNI is the molecule of the century, there's no doubt about it, and is an indispensable molecule, and is definitely much superior to ACE inhibitors in reducing the cardiovascular deaths, heart failure hospitalizations, and improving the quality of life of the patient, whether HFrEF or HFpEF, or even heart failure with improved ejection fraction, or heart failure with mildly reduced ejection fraction. ARNI also improves the ejection fraction in HFrEF and reverses the adverse LV remodeling, and improves the quality of life as per the Kansas City Cardiomyopathy Questionnaire in both HFrEF or HFpEF patients. ARNI should be initiated as early as possible in patients with ADHF or de novo heart failure. Here, time is life years. In fact, it has been shown that 9 years is the time which you achieve with starting this molecule early. So you can have a life more by 9 years. And ideally, this should be started well before discharge of the patient, or as early as possible whenever it tolerates. It should be given at least for 3 months, ideally to 3 to 6 months, along with other foundational 4 therapies, as I've mentioned, before putting an ICD or a CRT. Because if the patients are not responding or not responding less, and ejection fraction still remains less than 35%, so in such patient, you can put an ICD or a CRT. And ARNI should be used in all patients with HFpEF up to ejection fraction of 57 to 60%, along with SGLT2 inhibitors to reduce the heart failure hospitalization and improve the quality of life of the patient. So I think with that, I would like to thank you for a patient listening. Thank you.